work that you've done.
Thank you, Mark. It's good to be here, and thank you all for the invitation. My engagement in suicide prevention started back in about 1996 when, frankly, as a nation, we were not addressing suicide prevention as a public health problem. And through some good fortune and association, people started talking about it on Capitol Hill. Resolutions were passed, and basically suicide was determined to be a national problem that warranted a national solution. In 2010, 38,000 people took their lives in this country. It's the 10th leading cause of death. So the journey for suicide has been more about how do you start talking about this in a way that people understand its preventability and the hope that you can instill in people who struggle. So I think for us, the journey has been mainly first talking about it so people understand it a lot more, and the fact that it is a form of violence, as a self-directed violence, and there are interventions that we can apply that can prevent suicide from occurring. Not nearly as many as we'd like, I'm the first to say. In 2001, a National Suicide Prevention Resource Center was funded, and one of the mandates in that directive was to build the evidence base. Start working with the nation and the researchers throughout the nation and the people who deliver programs, and try to build a best practices registry. So those that want to intervene can do something, and in the spirit of do no harm, try to do that which has been shown to have some merit and certainly some promise. And so we started that process long before I joined the Suicide Prevention Resource Center, but it's been an ongoing collaboration with our partners at the American Foundation for Suicide Prevention. And today, as we sit here, we have about 106 entries on the best practice registry, with 13 more in review. So of those, certainly about 18 are evidence-based programs. The others meet a different standard, but still programs and evidence-based, or it shouldn't say evidence-based, interventions that certainly show merit. So that's a step in the right direction. When the national strategy was released in 2001, there was very little science behind suicide prevention, but through the courage of a Surgeon General who was willing to put it on his agenda, Dr. David Satcher, and certainly through the courage of people on this table, at this table with me, Mark Rosenberg, a lot of people started adding their voice to this issue. So we have the best practices registry. Very few states had a state suicide prevention strategy in 2001. Today, every state in the nation has a suicide prevention strategy. And as Mark said in the introduction, I was recently just afforded the opportunity to update our national strategy in 2012 with the support of Dr. Benjamin and a wonderful task force of folks who helped us do that. Why did we do that? Well, we've learned a lot. We've learned a lot since 2001. We know there are therapies that work. We know there are public health approaches that certainly have shown a lot of merit and ought to be implemented elsewhere. One good example that comes to mind is the Air Force Suicide Prevention Program, certainly one of the best practices. Took a very public health approach to this issue, saw a high rate of suicide amongst active duty airmen, and through a very comprehensive intervention, which had multiple levels, applied this intervention and saw a reduction of suicide by 33% amongst the active duty airmen population. In addition to that, they also showed reductions in other forms of violence, whether it be domestic violence or other forms of violence, which says a lot. And I think hopefully one of the things we should talk about is maybe it's time for us to start thinking about maybe what are the connections with other forms of violence, maybe by looking at risk and protective factors earlier in life, I think is a really strong, promising area. And if we do a given intervention, such as the good behavior game, we may see outcomes that are quite successful much later in life that were not the intention of the intervention in the first place. So there are examples like that, and I think for where I sit now, it was important for our field to come together, whether it's practitioner, policymaker, or researcher, or frankly the voice of the survivor, the bereaved community, and those who've made an attempt to help us figure out where as a field we should go. I think the revised national strategy is that vision and should guide our nation for the next 10 years. I also feel strongly that the time has come for us to start looking horizontally. I don't think the solutions to these problems are going to be vertical anymore. I think they're going to be horizontal, where we have to look at other factors that are contributing to the outcome that we care about, but also really help us realize that in a world where we may not have more resources anytime soon. There may be realities horizontally in other agencies, et cetera, that could help us advance the cause we care about. One example of that, and I think it's also relevant to this conversation, is in 2010, the Secretary of Health and Human Services, Kathleen Sebelius, and the Secretary of Defense, at that time, Secretary Gates, launched a public-private partnership, which is called the Action Alliance for Suicide Prevention. It literally is a public-private partnership chaired by the Secretary of the Army, John McHugh, and the private sector co-chair, Gordon Smith, who used to be the senator from Oregon, now the CEO and president of the National Association of Broadcasters, and brought together about 45 private sector and public sector partners, all of whom have a connection to a sector of interest. So they gather, they're meeting at least once a year, if not twice a year. 14 task forces have been formed. There's a sustainability committee. So there's an operational arm, if you will, to try to help the nation advance the objectives in the National Strategy for Suicide Prevention. And I think as we do that, and we encourage researchers to continue to contribute, and certainly potential funders to invest in some of the promising interventions that are out there, I think we're going to begin to see the kind of result that we're hoping for. And one of the things the Action Alliance did, and this will be my final point, Mark, is that they set a very bold objective to save 20,000 lives in 5 years. So they made a statement that we cannot keep just churning. We've got to set a measurable objective, and now we will start working with people who want to contribute to that measurable result and hopefully begin to quantify the value of some of the interventions we're investing in.
Thanks, Jerry. This goal of saving 20,000 lives in 5 years, how do you think you document that? What kind of evidence can you collect to show that you are successful? They're very clever because you probably can't collect evidence to show that they weren't successful, but it's a tough challenge. Again, how are you going to collect the evidence that you need to demonstrate success, as well as collect the evidence to target your programs or to expand your platform? But evidence comes back in many, many ways as a really important element of the work all of us are doing. And it's a pleasure to hand the stage over to you, Mary Lou. We were talking before this panel that both of us had worked together on violence prevention initiatives under an extraordinary leader, and that was Janet Reno. And one of the things that I think made her extraordinary was that she wanted to sit down and find out, what do the data show? To think about a political leader at that level as Attorney General, where you are in the midst of a political storm every single minute of every single day, but to stop and say, what do the data show? I think we both talked about how lucky we were to work with someone who had such tremendous respect for data. But Mary Lou, let me turn it over.